Clinical knowledge changes quickly, but getting that knowledge into everyday care is still slow and difficult. This demo shows how Trisotech uses AI, visual clinical models, and HL7 FHIR to turn evidence into patient-specific care plans. Be mindful that this is not a chatbot that simply writes care plan text. The goal is to create a governed pipeline. AI helps interpret clinical evidence. Visual BPM Plus models make the logic reviewable. Deterministic execution makes the reasoning explainable. HL7 FHIR makes the final care plan interoperable. Clinical guidelines and publications contain useful recommendations, but they are not automatically ready for patient care. Someone must interpret them, translate them into logic, apply them to the patient, and keep them current. That manual step is where delay, inconsistency, and governance problems appear. Here's a quick overview of the architecture for evidence to patient-specific FHIR care plan. During the generative authoring phase, clinical evidence is used to identify the relevant care planning logic. Next, that logic is converted into a visual BPM Plus model, including deterministic DMN decision logic. The model can be reviewed before use. Then, during the clinical reasoning phase, the patient's clinical context is applied. The deterministic model produces explainable results. Finally, the care plan writer agent uses those validated outputs to create a patient-specific HL7 FHIR care plan. Note that this architecture diagram was greatly simplified for ease of explanation and understanding. To demonstrate our solution, we will use a scenario of a traveler who becomes ill while abroad. Martin is traveling from his home in Paris to Egypt to explore as many sites as possible. Martin's known conditions prior to departure includes diabetes, hypertension, hyperlipidemia, obesity, and an aspirin allergy. During the second week, he develops loose stools and vomiting. A clinical note classifies the problem as severe traveler's diarrhea with dehydration, mild hyperglycemia, and mild increase in blood pressure. This scenario is useful because it requires the solution to handle patient-specific context, chronic conditions, medication and allergy considerations, acute symptom assessment, severity classification, guideline-based treatment, travel readiness logic, handoff, and follow-up upon his return.
So let's look at how this plays out. We identified 5 clinical practice guidelines that might apply to Martin's situation. In this video, we're going to focus on this one on traveler's diarrhea that was published in the Journal of Travel Medicine. As you can see, it's a relatively dense document, which would take some time to read and understand. And we've asked the AI to help out. So the first thing we asked it to do was to identify the clinical decisions within the guideline and represent those using decision model notation. In this case, it identified 5 different decisions within the guideline and deployed them to the Trisotech platform. And we can see one of them here. Here we see the various inputs that it expects, and then the decision matrix, which is going to result in a severity classification, which we can use in other decisions to arrive at an appropriate care plan. At various points, we're going to use deterministic scripts to validate, lay out, and deploy that DMN to the Trisotech platform. Once that's done, we want to create a care plan writer agent. So we ask the AI to write a skill file. Within this skill file, it includes information about the DMN, which is available as an MCP tool to be called, and other tools such as the ability to look up terminology and to validate FHIR so that it can ensure that the resulting care plan resource is well formed. Both this skill file and the DMN that was generated is reviewed by a clinician to ensure that it's going to result in appropriate care plans when applied to patient data, which we can now do. We can take Martin's International Patient Summary, which we see here, and the note from the doctor who visited him in the hotel room, and supply that to the agent. And the agent will then extract from it the information it needs. For example, from the note, it finds that he was unable to leave the hotel room and so was incapacitated. From the International Patient Summary, it finds his age and the fact that he has this allergy to aspirin. It could then start calling the DMN in order to arrive at an appropriate care plan. For example, it can use the fact that he is severe but with non-dysentery, but does have a fever, to arrive at a recommendation for what antibiotic to prescribe. We can come over here and see a representation of the resulting care plan and the goals, conditions, and the patient resource, all provided within a bundle that also includes a provenance that links to an AI device. This implements the AI Transparency on FHIR Implementation Guide, which provides observability into how AI was used in the generation of this care plan. We see the goals that have been set, and we see the treatment that has been recommended and where those recommendations come from. We also see that because of that allergy to aspirin, we are recommended not to do certain treatments. Within the provenance, we also provide linkage back to the original clinical practice guideline for review by the clinician before applying this care plan to the patient care.
The walkthrough proves 4 important points. First, clinical evidence can become computable. Second, the logic can be shown visually so clinicians can review the clinical intent, conditions, and recommendations without having to interpret code-style logic artifacts. Third, the reasoning can be executed deterministically so it is repeatable and explainable. Fourth, the final care plan can be represented using HL7 FHIR, so it can support handoff, exchange, and downstream use. HL7 is central to the value of the solution. The International Patient Summary and other FHIR resources provide portable patient context. FHIR CarePlan provides a standards-based way to represent the resulting plan. BPM Plus complements HL7 by making the guideline logic visual, computable, clinically reviewable, and governable before it is used to generate the care plan. Clinical reasoning should not be hidden inside a prompt or buried in a technical artifact that clinicians cannot easily inspect. In our approach, scoring, classification, contraindication checks, triage, and recommendations are handled by deterministic models. Generative AI is used after that to help assemble a readable care plan. The result is reviewed before use. This keeps AI helpful without giving it unchecked clinical authority. The solution avoids hiding clinical reasoning inside opaque prompts. No autonomous clinical action is claimed. The expected impact is practical. Clinicians can review the logic more easily. Care teams can produce more consistent care plans. Patients benefit from plans that are more current, portable, and specific to their situation. Health systems can reuse validated models and update them when evidence changes. Our solution can be evaluated using measures such as traceability, reproducibility, FHIR conformance, review time, and handoff usefulness. The main idea is simple. AI helps turn clinical evidence into computable clinical intelligence. BPM Plus makes the logic visual and reviewable. Deterministic execution makes the reasoning explainable. HL7 FHIR makes the care plan interoperable. Together, these create a safer and more scalable path from evidence to patient-specific care.